clarify the question. So I'm just wondering, when you're talking about the standards, is your question that should we look at an Indian standard, or is your question around, say, the problem
Dealing
of
with multilinguality, like the point of standardization and drug names, right? But then with diseases, with ailments, with many other common nouns, maybe not even proper nouns, right? You'll need Indian language equivalents.
Right.
I mean, I know that there is some effort from the ABDM and others to have a so SNOMED localized, right? Localization.
Right.
So, what has been your on-ground experience with the with Indian language incorporation for common nouns, for verbs, etc.?
Yeah, actually, I was in a conversation about a couple of weeks ago with a much larger ecosystem provider, a platform in the Indian ecosystem. And they've actually started looking at some of the language based customization on top of the existing ICDs and SNOMEDs. So rather than trying to build a new system, they're also looking at, okay, what are the various commonly used, and you have to start with the 80-20, right? So you pick the most commonly occurring conditions and so on, and you start to try to create mappings of those. So I think that's where some of the industry, and we've not reached that point, but that's what we're seeing some of the industry starting to do. And there definitely is a need, but there, what they have is that, they still have doctors that work for them. So it's a more controlled environment, right? So they're able to look at, again, narrow the problem even more and more and say that, for the common cold, what are the various terms in, let's start with a localized geographical area, then we sort of expand it out. I think that's how they're going, but, I'd be fascinated to see if, some of the things happening in terms of localization globally in terms of technology, and I'm sure you and other people in IIT are leading a lot of interesting research and work out there to see if one's able to kind of even map medical terms like that. It would be very, very fascinating to see.
Thanks for that. So, would you be actually interested in collaborating with KCDH on the angle of multimodal input, audio input, and also languages, multiple languages? Is it something interesting? Because we have many other faculty members who.
Yeah, let's take that offline. He's very enthusiastic about collaboration, but let's not put him on the spot here.
Sure. Thanks.
I'd be happy to take that offline. Thanks.
Nice hearing you.
Any last questions? Okay, great. Thanks a lot, Nipun.
All right, thank you.
It gives me great pleasure to introduce our next speaker, Mr. Sasank Chilamkurthy. He is an alumnus of IIT Bombay, and he has had quite an illustrious career so far, and hopefully going forward as well. He's a founding member and AI scientist at Qure.ai, which is one of the most successful medical imaging startups in the world. Perhaps it's not even no longer a startup. It's now it has FDA approvals and so forth. He's also a co-author of PyTorch AI framework, and his work involves deep learning on medical images obtained from radiology. And his passion lies at the intersection of AI, healthcare, and open source technology. He has contributed to the development of AI in healthcare and is instrumental in development of Qure, which is a neuro AI tool. Over to you, Sasank.
Thanks for the interesting, Professor Sethi. I'm really blessed to be here, I think. Thanks for inviting me, KCDH. Being part of the, alumni. Yeah, I've been part of the electrical engineering as well, which Professor Sethi works in, right? So I'm really blessed to be here. To be honest, a lot of stuff I learned from IIT Bombay, I literally apply them, like radon transform, posterior spheres, which a lot of convex optimization courses that I have been part of. Professor Ganesh is actually taught me that course, who just asked me a question. Who just asked a question, right, to the previous speaker. I'm really blessed to be here. So what I'm gonna do, let me, can you guys see my screen?
Yes.
Okay, so what I'm going to do is I'm going to give you a pitch slash presentation of one of our, I mean, more specific products. So this is, for example, a page, I mean, a presentation I have given in a neurology department. So you can understand, I mean, so basically the idea is that I'm go really deep. Instead of giving you like upar ka funda, I mean, instead of giving you just about basic stuff, I wanted to dig deep and explain you like more neuroscience work that we ended up having to do, right? So I'll do that because as part of, so if you're a healthcare startup, you will realize very quickly that devil is in the details. You will quickly realize that's where most fun is as well, right? So that's what I will go deep into. Instead of giving you more philosophical or abstract things, I'll go really deep, right? So I mean, I'll before that I'll just intro what we do, right? At Qure.ai, basically what we do is we apply artificial intelligence, deep learning on medical images, basically X-rays, CT scans, ultrasounds, right? So right now, I mean, we have just raised, by the way, a 40 million round last week or a week before. So fairly well funded. We have about 100 plus employees, 150 employees today. Interestingly, we have, unlike other places, other AI startups in the space, we have very narrow focus on disease areas. Because again, devil is in the details, and each disease and each condition is different from other conditions. And I mean, we are a AI guys. I mean, data scientist dream. We have largest repository of 1 million images. 1 billion, sorry. I think I called it 1 billion. It's actually a 1 billion images that we have internally that we use to train our models. And every year we basically process 200 million images, right? So this is the overall different AIs that we have. We have an AI on CT of brain, we have AI on CT of lung, and we have an AI of X-ray of chest. So I'm going to specifically talk about, I mean, basically brain related stuff, neuroscience, right? And then we also have, we realize that it's also important for us to not just have AI, but to have a complete end-to-end solution. I'll talk about this as well in more detail. But overall, I mean, so this is a kind of footprint that we have today. We are in about 50 countries now. We have operations there, and we have about 400, I think it's 500 now, 500 plus sites across the world that are using our AI. So we impact about 10,000 patients every day. And I think, I mean, we are actually probably instrumental in at least actually impacting lives. Sorry, actually impacting critical, maybe 10,000 people, right? I can probably confidently say I have saved them using the algorithms that we built, right? And this is different people that we work with, a lot of ministries of health, a lot of universities, like Indian health, I mean, a lot of Indian places as well, Niti Aayog, all these people we work with, Gates Melinda Foundation, right? And we are very research heavy. We publish a lot, quite a bit. So we have 37 plus journal peer reviewed publications. If you count conference publications, I think it will be like 150 something. I think this month alone we submitted 6. Like March alone we submitted 6 conference proceedings. So we are very, very active in terms of, I think that 4 patents is now 6 US patents. So super active in terms of science. So collaborate quite a bit with a lot of people around the world. I think one of the best papers we have is the Lancet one. I don't know if you guys remember if you guys know about the Lancet, it's the most prestigious medicine journal in the world, right? For example, all the vaccine trials, right? They get published in the Lancet, for example. It's that impactful. So we have got our AI stuff published there. So this is in general about Qure. I will talk more about stroke. I will talk specifically stroke. Maybe I'll give you a brief overview of what stroke is and how the stroke treatment works. The stroke is essentially part of your brain not getting blood. Let's keep it very straightforward. So heart attack, if you know, is basically your heart muscles itself not getting blood, right? That's what heart attack is. And therefore your heart is dying. and your heart has stopped working. Similarly, it's brain stroke, also called as brain attack, is when brain is not getting blood, and because brain is such an important part of the body, if the brain doesn't get blood, the person will die very quickly, right? It's as I mean, so if you don't treat the stroke patient within maybe a day or two, and you kept them without any care, they will die. I mean, patients will die. It's really life-threatening condition, right? And thankfully, there are treatments, and more treatments are coming. More treatments are already proven in this space. I'll talk more about the exact treatments, but overall, so the how the stroke patient is treated is also important to understand this discussion where I'm going to. So by the way, why I am going through this is because this is how our data scientists and our engineers and everybody in Qure thinks. We think we have to think extremely intense into actual clinical area, and then we also have to be good with data science and stuff. This is basically the bread and butter of us. So that's the reason why I'm giving you a taste of how working in AI startup in healthcare looks like, right? So I'm just going into one deep dive, doing a deep dive to give you the taste. So how the treatment look like is patient comes to the stroke center, right? Through the ambulance. Is there a question? I think I hear some echo. Is there a question? No. Okay. Good.
No, I think someone accidentally unmuted themselves. I will mute them.
Got it. No issues. So how it works is I'm just being quick on my time. Yeah. How it works is basically a stroke patient comes to the stroke center. And then what happens is basically they will be evaluated whether it's stroke or not. Then they will be immediately be taken to a CT scanner, where they will be taken a CT scan. So CT scan, computed tomography, right? And then radiologist will be looking at this CT scan, and he will give his opinion to the emergency doctor who looks at the, who basically ordered the CT, who was in charge of the patient. So emergency doctor confirms that yes, this is a stroke, and yes, this is this kind of stroke. Then he calls a neurologist, and he calls a neurologist. Neurologist is basically a doctor who is specialized in brain related stuff. Neurologist again looks for this, looks after all the data that is generated so far, whatever analysis of emergency doctor, radiology, CT scan, and the patient symptoms. He looks at all this information and he makes it. So he then decides, okay, what treatment do I give to this patient? So there are two kinds of treatments to the treatments that can be given to the a stroke patient. Number one is medical treatment, which is there is this specific drug called as TPA, right, or altiplase. So this particular what it does is this dissolves the clot, and then there is another set of treatment called as thrombectomy, which is more surgical. It's minimally invasive surgery. So surgeon will basically insert a catheter into the vessels, artery, and then will pull the clot out, right? So you don't need to know exact details, but know that there are two kinds of treatments, and neurologist basically makes a decision. Both of them are not lightly taken. So you'll have, it's not like just give aspirin kind of thing. It's a lot more complicated than that. So neurologist basically decides based on all the information, and then he calls up surgeon who actually does the surgery in case it is required, right? So as you can see, this is, I think, briefly informative of pretty much like any kind of treatment that you get. It involves like many people. Like if you do any complicated, if you go with any complicated disease such as stroke, this is the kind of process that is followed. It involves multiple people. It involves like multiple data crunching. Let's say that whether it is done by, it's mostly done by humans at this point of time. And then all this takes time. It's not synchronized. So they have to call each other. Like for example, the information, all these arrows that you see, these are literally phone calls, like calling, hey, CT guy, can you please prioritize this patient? This patient is a stroke guy. He requires immediate CT scan. And then the CT scan guy will call radiologist and say, dude, radiologist, this this guy is like really important. Can you please report and tell me what's up with this patient and call emergency doctor? And the radiologist will then call the doctor and confirm, okay, this patient has left side weakness. Okay, that's correct. I see an infarct on the other side. So things like those, right? This is in general the way in which we look, and we aim to fit in this. The way we want to fit in how we use technology is, number one, help them with diagnosis, help them with AI. So this like many, so as you can see, right, there's many arrows which requires a lot of data processing. So all that will be taken care by AI, right? And then there is a lot of dissemination of alerts because stroke is a time critical disease. So there are alerts that you need to give intelligently that, hey, this patient requires your intervention. And then support and collaborate them with faster decision making, which basically gives them all the information in one place. So this is the way in which we reimagine the whole stroke workflow. Patient arrives at the spoke center, and as soon as they arrive, we know about the patient in the app, and then they'll be taken to the CT scan, and the CT scans will be available on the app, which will then be transmitted to all the people at the same time, all the different doctors at the same time. They will know what exactly they want, and then they can collaborate and decide on the treatment decisions. Right. So this is the brief for you, and I will, in interest of time, I will basically discuss how it actually works, and we'll stop there for further questions. So this is actual screenshots of our app. So how it works is, so as soon as the emergency case is done, so we will be able to take some of the information, right? What's the first name? What's the name and basic information, patient information, followed by, this is very stroke specific information. What's the blood pressure? What's the SpO2? I'm pretty sure now we heard of SpO2 now. What's the blood glucose levels? When was the patient last well-known time? And then there is this stroke scale, very specific form for stroke alone. This is called as National Institute of Health Stroke Scale. So there you basically ask questions like what's the level of consciousness, whether the patient is drowsy or alert or is in coma, right? And then you ask like, okay, how about you ask patient to close the eyes? Is he able to close the eyes? Is he able to like give you, like if you ask him current month and what's his age, will is able to answer that, right? So basic, I mean, stroke related questions. This is so this will be filled by the emergency doctor as before the CT scan is taken. And as soon as the CT scan is taken, it will be sent to our app, which you can look at the CT scan and also AI related findings and AI. So all this information, right? So this is FDA approved. AI will run the algorithm on these CT scans and will tell you what kind of abnormality is there in the brain, whether it's intraparenchymal. These are different types of stroke or different types of trauma. Basically, a CT interpreted, right? This is super duper accurate. 97%, I mean, plus accuracy. If you're, I think I can put up the term AUC, which is one of the accuracy metrics, right? And it's trained on like 2.2. I mean, it's trained on billion plus images. Super duper accurate. As probably as accurate as a resident, somebody who just got, who is not too experienced in the radiology, right? So it can detect like 12 abnormalities, and it can basically create a fairly fully automated report. So this is on something called as non-contrast CT. Not only that, it can also quantify, for example, how much big a bleed is, right? And he can then also quantify, for example, if you know the brain is symmetrical. So brain left and right are symmetrical, but in this case, you see that this is not symmetrical. The left part of the brain is not same as right part of the brain. So we actually quantify the symmetry. It's called as midline shift. So we actually quantify how asymmetric. So this something called as herniation of brain. So we quantify the herniation, and we can tell you like all this super quickly in your app. So then there is this specific for a specific type of stroke called as ischemic stroke. There is also something called as aspect score, which can help you identify early signs of stroke, right? Even before it can be seen on CT. So it can eliminate, basically this eliminates a subjective, this aspect score is fairly subjective in terms of humans, but AI will eliminate the subjectivity that is involved because it is dumb and it will give you same result for the same patient, right? So this is the aspect score map. I mean, I will not go into exact details of what this aspect score is, but this allows you to take the decision on whether, okay, this patient is ischemic stroke patient, and then, okay, this patient has aspect score this much. So now should I give this patient a medical treatment or a surgical treatment, right? And this is very useful in case you only have limited information. But you can also get more information called as angiogram. So what you do in angiogram is you inject so-called contrast. So if you inject the contrast, you can basically see the vessels, right? You can see the vessels of the brain. You can see, for example, like all the, I mean, white stuff, right? That's basically blood vessels. You can see that this is again asymmetrical. On the right side of the image, you are able to see the vessels, but on the left, this same vessel is missing. So this is something called as large vessel occlusion. So a significant part of the brain is not getting blood. And this you can treat this with surgical kind of treatment called as thrombectomy. So this image is generated and automatically we can say whether this is a large vessel occlusion or not using AI. So this MIP, what you see, this is called as maximum intensity projection, and it requires some AI stuff. I will not go deep, but this can also be created using AI, and we basically detect whether this large vessel occlusion is present or not, right? And then finally, most interesting, there is, so not only do you want to know if you want to treat a stroke patient, whether this is a stroke, whether this is an ischemic stroke or not, whether there's a large vessel occlusion or not. You also want to know if you do surgery or intervention, whether the patient will actually recover. So for this, you do this. I hope you have. I mean, I'm pretty sure you guys have heard about this fMRI thing. Similar to fMRI, there is this functional imaging called as CT perfusion. So what this CT perfusion does is it tracks flow of blood using contrast in your brain, right? It tracks your contrast, it tracks your blood flow, and it will create basically something called as Tmax and CBF. Fairly technical terms. What these do is, for example, this area Tmax, right? This shows which part of the, so this is, by the way, this is all automatically generated. This does not, you don't see them from the, this is all AI generated outputs. So what you see here is this part of the brain is dead. So this part of the brain, like even if you do any treatment, you are not going to do anything with it. But here, if you see this larger, far larger part of the brain, which is less bright, right? So this is basically salvageable area. This is not getting blood right now, but if you treat it, it will get blood. All these areas that are around, right here. So this is the core basically where the blood is completely, where the brain is completely dead. So basically you can see them here. So these all you can recover, all these areas if you treat them patient well. So this is called as perfusion imaging, and this is, by the way, it's a fun project, a course project probably, to create basic perfusion imaging for fun. So all this is we do using AI, right? So and then all this data is shown in one place because, like, if you remember the process, it's important. It's all of these are bit and parts of the data. I mean, the physician does not look at one thing and make decision. He looks at many different things and make decision, and all of these things are located in one single place, right? And you can actually, not only this, you can manage patients remotely using so-called hub and spoke model, even though the patient is because it's a telestroke. I mean, so because it's a stroke, you can treat them at home, but you can treat the patient at a nearby primary health or secondary health center. But the doctor who is treating them, the super specialist can sit in the, if they have access to all this data and basically do a video call, he will be able to treat a stroke, really complicated disease, inpatient complicated disease, directly from a high-end center in Delhi. And this is literally what's happening. I'll skip through all this because I don't have too much time. I'll just discuss one particular the way in which this is being used. So this is close home in Tezpur. I mean, I can also emphasize some of the US or UK, but I want to emphasize more Indian because in Indian story. So this is close home, a city called as Tezpur. This is in Assam. So this is hospital called as Baptist Christian Hospital. This is a 130 bed secondary care hospital. in Assam. Right here, there's a high prevalence of hypertension, therefore huge amount of stroke prevalence. In fact, there is a specific type of complicated type of stroke called a hemorrhagic stroke, much harder to treat. This is actually 50% of all the stroke cases here. So huge burden and a lot of challenges here. No specialist. This hospital has no radiologist, no neurologist. All the stroke patients have to be treated by a local general physician, right? Non-specialist, right? What happens now with introduction of our technology is that as soon as the patient is here, they get a CT scan, and the CT scan is transferred to both the physician at the center. The CT scans report is also sent to him. All this information is also sent to Dr. Jairaj Pandian, who is sitting in Ludhiana in Punjab, right, on the completely other side of country, and he basically coordinates the treatment and tells them, hey, this patient is eligible for thrombolysis, please do thrombolysis. And this is happening right now as we speak, right, live. Some patients are being impacted. Yeah, so I'll quickly, I think, yes, I have matched my time. I will not go deep, but I'm open to questions. I'm open to discuss details of anything that you are interested to know.
Thank you, Shashank. Very interesting and very real work that is affecting people's lives. We have a couple of questions here. Aniruddha, do you want to ask your question? So his question is, what AUC is required for FDA approval? Does it differ in AI for computational pathology, and is it different in India?
So number one, so I have spent about 1-2 years spending my life running clinical trials for FDA and all the other papers, clinical work I did. You need to understand that FDAs are also very sophisticated with respect to understanding AI stuff. They will reject if you say AUC is my endpoint of your clinical trial. In fact, they will not be happy if it's AUC. So they will be looking at sensitivity and specificity. So if you know the debate in the AI world, it's about generalization. The generalization is a huge difficulty right now. Even if the AUC are similar, the threshold that you use to threshold saying yes or no, and the related sensitivity and specificity, they change even if the AUC number is same across different data sets. So FDA is very specific. They are very sophisticated in this respect, and they will ask you questions a lot deeper than that. So they will be asking you sensitivity, specificity. They will be asking you sensitivity and specificity for each abnormality that you're talking about, stratified by each kind of machine that you are targeting, the patient demographics, whether there is. I can show you a, you know what? Just give me a second. I will show you one of the clinical evaluation reports that we create. I think you'll get an idea.
So, just building on this question, when you say every pathology is looked at differently by FDA. So let's say if it was not a stroke, in the MRI they found, in the CT scan they found AVM or any other arteriovenous malformation.
Yes.
So would that be picked up by the AI? Would that be having the same sensitivity and specificity, or would that differ by using the same AI? So it would be a like a coincidental finding, but the patient is presenting with all the symptoms of a real hemorrhagic stroke.
So they will want you to make sure that you have these confounders in your analysis. They will want you to make sure that you are calculating sensitivity and specificity on them and show that it is reasonably good, and you don't have too many false
positives. So what is reasonably good actually?
So the reasonable is the way they define it is way we have defined our endpoint, right? Is that sensitivity and specificity, its confidence interval, lower bound of the confidence interval is greater than 0.8, right? So 0.8, yeah, 0.8. So that's so if you are getting, I hope you understand this, all the stat stuff. So basically that's the kind of thing that they want. So it's statistically significant relatively high sensitivity and specificity. So if it's the sensitivity of lower confidence interval of 0.8, it will require you to have sensitivity and specificity of 0.95 something, because you're also limited by sample size calculations, because you cannot run trial with 10,000 patients. You will want to run trial with like reasonably 1,000 patients. You will have 100 abnormals, and then you calculate the confidence. Yeah.
So does the FDA mention this in their SOPs or guidelines, or they keep on changing, or?
Yeah, unfortunate part is, or fortunate part is, they are agile. These regulators are agile. They say, I mean, because about 3 years back, they were also quite new with respect to AI. So they did not know, for example, then that performance might differ between models of the CT scanner. They were not that savvy. Now they do. Now, if you submit an AI, I think they were not checking, for example, give me stratification by number of slices of CT scanner. Now they do. And then they'll ask you to quantify sensitivity and specificity stratified by manufacturer and how recent it is. So they're also keeping them updated. So you'll have to be on the toes, I suppose.
Okay. So this is US FDA. Indian perspective will be different.
So the thing is, in India, there is, I think, at this point of time, the regulatory scenario is not super strong. So it's treated on par with medical devices and nothing more. What I mean by that is, think that the regulatory environment in India treats AI not very different from a CT scanner or a syringe or like a injector.
But when you take an example of Tezpur in Assam as compared to any city in US, would the same guidelines apply?
So far as we I mean, abide by the highest guidelines, because we are, so far as it's like the max of all.
Okay.
So if so we'll have to work with the like most regulated environment, because
the most stringent, and they will apply it to the whole of the world. And one more thing, at the end of the report, do you mention that this has been diagnosed by Qure.ai or something like as a companion diagnostic tool?
Yes, it does.
Is that required in all the reports?
It's
and
not
is that
required, but we do it for the sake of sanity, because we don't want to mislead the docs either. Because
no, understood. But do the patient have any questions about it? Is the diagnosis being made by a teleradiologist, and has Qure played a role in that? Does that affect the doctor's perception in Delhi, or any other secondary look by the doctor?
So initially, there's always some, I think I will answer a bit broader than what you asked. So initially, there's always resistance. So like there'll always be some false positives and false negatives, and you want to make sure it's well communicated in terms of disclaimers that, hey, look, this requires a radiologist to double check before you make sure it's before you take complete action on the patient if you're not very confident, right? So that much we have to do disclaimer. But the way in which it's going on right now, from my from the customers I speak to, they say that earlier, I mean, I used to get patient in the night, and they used to take a CT scan of it, CT scan of the patient, and then I used to get called up in the night at 3 o'clock in the night, and hey dude, what's up with this CT scan? Is the patient fine? Right now, what's happening right now is, as soon as we are giving AI's report to the patient, and then patient is taking to the physician who ordered the CT scan, right? Actual, like in that, you remember the graph, this emergency physician. Emergency physician is not calling anymore the doc, the radiologist. So it's it's the acceptance is, I think they're very appreciative once they get used to it, that I mean, I literally can save patient life in this. Yeah, I hope I answered.
Okay, yeah, I got it. You were showing me something on the screen. You were sharing something.
No, I'm not.
Yeah, we are already exceeding time. Let's take one more question from Professor Ganesh.
No, before that,
thanks, Sasank.
I want to say hi to you for teaching me convex optimization.
Hi. Oh,
and although
nice,
EM
nice.
and all that stuff, expectation maximization, I literally use that.
Okay, great. Nice to connect back to you, Sasank. Nice talk. I mean, see, when we deal with more than two classes, like NWA classification, let's say different grades of cancer, or even with stroke, I'm sure you have grades, right? Often the tendency is to ignore the, you often have a heavy tail, right? As such, most of these are finding needles in haystack, and then you can have thicker and thinner needles there. That's where I think the whole, I mean, I was happy to hear you mentioned the word agility, right? There has been agility in the metric space, but yet there is this to and fro kind of a negotiation or bargaining between what's possible, what's feasible in the AI world, and what's the user interest. Have you tried creating some kind of dashboards internally, or some? I'm not talking internally in the sense of the AI developers, but I'm talking about the stakeholders, right? Where they can really find, like we talk about Pareto optimality, but maybe there are other notions of trade-off, other kind of balance points that balancing between true positives, false positives, between macro versus micro measures. So, what's your experience in that space, especially with heavy-tailed, distributions?
Yeah, I can. So I can completely appreciate where you're coming from, because the kind of findings you will see in an X-ray are immense. You can see up to 200 odd findings in an X-ray, and we have about 5 million, 10 million images, right? And there are some findings, 5 million, 10 million at least images of X-rays of chest. There are some findings of which we only have 200 of those in our database. So it's that 200 out of 5 million, right? So probably like 3 parts. I mean, more like 200 by 50, 10 is like 20 parts per million. So huge long tail in this space, right? So the way we work around this is that our models basically only pick the most common ones, realistically speaking. And that's the reason why this cannot be on its own. Like in the end, it's a tool. So I mean, you cannot expect COVID test, RT-PCR test to work and pick up a TB scan. I mean, TB patient. It's a tool. I mean, it's like you have a hammer and you use it to hit a nail. You don't try to eat pizza with it, for example. So that's the reason, in fact, like why we have such a disease focused way. In which, for example, I have presented stroke, right? The stroke is a focus because I have clear boundaries of what can be seen, what cannot be seen, what are stroke mimics. For example, somebody picked up AVM. That's a good example. So I know that AVM is a edge case that I will come up with my stroke patients. So we're dealing with that right now with data augmentation, finding more data, and for example, boosting and all those things. So now coming to your question of other ways of optimality, right now, as of today, the knowledge for the doctors, forget doctors, to be honest, even for most engineers in this space, if you talk to any IT guy in a hospital, if you say AUC, their mind will be blown. I mean, they are like, they were not there yet, and I don't think even explaining sensitivity and specificity is not very easy to a lot of people. So I don't expect, so we have earlier used to basically give a score to people so that they can ostensibly, they can make better judgments, right? If I give, instead of giving a 0-1, I can give them more information between 0 and 1 a number, right? But this was actually very negatively received. They did not want that because not only do they have to think about the actual patient, they also have to think what AI thinks it says, and it's extra piece of burden in their mind. So from the human interaction point of view, they prefer less thinking. So in the end, the whole idea of AI is to distill the information in the, like, take complicated set of information, distill it into actionable, simple stuff. That's what you have. It's a dimensionality reduction in the end. So you want to decrease dimensions as much as possible. So that's the general. I hope I have answered your question, although better around the bush a bit.
Yeah, I like that perspective of dimensionality reduction. That helps a lot. Yeah. By the way, Sasank, please do visit KCDH once. Yeah, very nice to hear from you.
I have visited quite. I mean, I come and collab with Professor Sethi quite a bit. We have actually a project.
Oh, great. Great. Thanks.
Great. Let's see. Is there one more question? Do the same principles apply to pathology too? Yes, the same principles will apply to pathology as well. Yes, Anirudh. Yeah. There, the added thing is that you have a very large image, and then it's also a spatial needle in a haystack. So that is the reason that, and then it is not natively digital. People are so used to looking at glass slides and not investing in digital scanners that it has lagged. AI in pathology has lagged that in radiology quite a bit, but I think it is soon picking up. Okay, with this, let's conclude this session. I want to thank both Nipun and Shashank for very great and informative talks, and to all the participants for asking these questions to make it lively. So with this, we are concluding this session. Thanks, everyone.
Yeah, I'm also thankful to the Professor Amit, who is chairing this session very wonderful, in a very wonderful manner, and drive the session very smoothly. Thank you, Professor Amit.